Hello and welcome to a new episode of Home of Medicine podcast in association with the Royal College of Physicians, Edinburgh. My name is Ben Lovell. I'm a consultant working in acute medicine in London in the UK, and I'm joined by my wonderful co-host again today.
Hi, I'm Dr. Amie Burbridge. I am a consultant in acute medicine, and I'm now a director of professionalism at Lincoln Medical School, which is still very new and sounds very strange for me to say.
But it's lovely to hear.
Yeah. So you have a case for me.
Yes, I do. And this is what I call an ambulatory care case, because that's the old language. But I think you would call this SDEC, wouldn't you? Same day emergency care. We officially rebranded, but you stick with what you learn with. So we're in SDEC, and this is a patient. It's a young man. He's 29. Sent him by the GP because he's, let's say slightly breathless and feeling a bit weak. Not his normal self. And the GP referral letter was quite sparse, normally fit and well, young man at the age of 29, feeling a bit weak and washed out over a period of about 3 weeks and more breathless than usual. Please see and assess query PE. That was the referral. So I went to the waiting room to call the gentleman in to the clinic to make my assessment. And the patient stood up and followed me in and looked the absolute picture of health. A strapping young man, very healthy looking, very well built, obviously very athletic, shining with good health, really, follows me into the assessment room. And we sit down and I say, tell me what's been going on. And he says, I'm just not my normal self for about 3 weeks. I'm more tired than usual. I'm not able to run as far as I could when I go for a jog, which is strange. Sometimes I just feel flat. He said to me, I feel like my engine's gone and I don't have the oomph and the wherewithal that I normally have. I'm normally a very fit and active person, but I'm just unable to do what I could normally do. I'm stopping halfway up flights of stairs, which I've never had to do before. And I said to him, did you have some kind of viral illness which preceded all of this? And he said, no sort of acute febrile sickness or anything like that. And it came on, he reckons, about 3 weeks ago, not overnight, but it's been getting slowly worse day by day. So that's the hook, as it were, of the case. What are your immediate thoughts on the data so far?
So I've got a 29-year-old male that has no past medical history of note.
Correct.
And has had a 3-week history of gradual breathlessness, feeling weak. And the GP has referred him in to query a pulmonary embolism.
Yeah.
And on your initial sort of end of the betagram is that he looks very well. He looks like a picture of health, but he says that he's tired, he can't run, and that his engine is flat and gone empty. And I certainly know how that feels sometimes. Exhaustion, you just can't do anything. So, am I worried? Probably not, to be honest, initially. You said that he looks well, gradual breathlessness over 3 weeks, query PE. So that I guess I need to think about, why did the GP think this gentleman had a PE? Has there been any risk factors, any recent travel, any family history of any blood clotting, DVTs, any PEs, any history of coagulation, cascade disorders, either familial or himself? Any long haul travel that he's been on? So I want to ask those questions. The weakness, is he anemic? Why is a 29-year-old man anemic? Has he changed his diet recently? Has he had a change in bowel habits? Has he vomited blood? Had he passed blood from the back passage? Has he had any hemoptysis? I mean, basically, I want to ask every single question from every single system, because it's it's not a woolly or a vague presentation, but weakness is he breathless on rest? You said on exertion, but is it there at rest? Can he lie flat at night? Does he wake up at night gasping for breath? Is he wheezy? Any chest pain? Any widespread body pain? Any weight loss? Any night sweats? Basically, the list is endless.
All right. Which one do you want me to answer first? Okay, lots of very, very good questions. So this is tired all the time. I remember learning about this in medical school. I think it's one of the biggest presentations to primary care, actually, or at least it was back in the day when I was a trainee. TATT, tired all the time. And causes of tired all the time, I go through the similar sort of cycle that you did. I think hematological, so anemia. I think endocrine. So I think, is it a newly undiagnosed diabetic, or if their thyroid gone off and they're hypothyroid? I think about occult malignancies, very rare. I ask a few questions about those. And of course, I think the main culprit in all of this is psychological. Is it life? But you don't make too many assumptions at the front door. And there's a few things I like to go through first before I come back and say, listen, what's going on in your private life and your personal life? Anything that you think could be adding to this feeling of tired all the time. So a pretty similar process to you, really. So I asked him a lot of questions. Any chest pain? No. No pleuritic pain, which would make you think PE. No central cardiac sounding chest pain. But then again, why should a 29-year-old ever have cardiac sounding chest pain? I asked about things like weight loss and appetite. Appetite's okay, hasn't lost weight. And he would know this because he is someone who tracks his fitness very well. He goes to the gym, very muscular, looking at his, I don't know, what do muscular people do? They add up their fat contents and muscle percentages.
Macronutrients.
Yes. Yeah, he was doing all of that. So he wasn't losing weight. He said that, I said, are you breathless all the time? He says, no, it's when I'm trying. So it's at the gym, it's going up the stairs, it's going for a run. But when he's still, he's not so breathless. He had not experienced any PND or orthopnea, and he had not noticed any ankle swelling at all. I thought about, has he potentially got a new undiagnosed small airways disease, an asthmatic? Do you wheeze? Do you have a cough overnight? Is the breathlessness worse overnight or first thing in the morning? But there were no real patterns that I could find. He didn't have a history of any other atopy, such as hay fever or eczema or allergies that would go with the new small airways disease diagnosis. So that's respiratory. We've done endocrine, we've done cardio, we've done hematological. I haven't got his blood results back. You said at the beginning, would I admit this person? And my thought was, there is no way this man is being admitted to hospital. Nothing can come to light in this ensuing consultation that would make me admit this man to hospital, because he does not need hospital treatment and we can manage this as an outpatient, because he looked healthier than me. He looked very, very well. Wasn't needing oxygen, wasn't needing anything intravenously as far as I was aware. And to answer your other question, what made the GP think this could be a PE? It's difficult because you don't get to have that conversation, do you? They just, when the patient comes to the paper. So was the GP just thinking, gosh, what could cause breathlessness in a young person? It's not going to be angina or COPD. So let's say PE. Maybe it's something I can hang a diagnosis on to get them seen by an aesthetic doctor. But I couldn't elicit any triggers for a venous thromboembolic event, such as all the things you've said: recent surgery, coagulopathy, thrombophilias rather, long haul flights or immobility, nothing like that. And he hadn't noticed any calf swelling that would indicate a DVT.
Does he take steroids, anabolic steroids?
Why do you ask?
Because anabolic steroids that you can purchase, maybe at, I don't know, at some gyms I know sell them, and you can buy them off the internet. So I'm going to think about this. So steroids, they're often, when you buy a steroid that may be off the internet or over the counter or illegally, they aren't often just steroids. You don't just often get the anabolic steroid portion. It's often mixed with other medication as well. So sometimes testosterone, sometimes insulin, sometimes estrogen. So it's not often the anabolic steroid that you think you're getting. So has this individual got some steroids? Is he taking them? Has it caused some esophageal irritation that has led to inflammation, that has led to some bleeding and some iron deficiency anemia, which has led to breathlessness? Yes, that is a stretch.
I asked him, drug history, doesn't take any medications. I asked him, do you take any other drugs, any recreational drugs at all? Flatly denies it.
Okay, so I mean, I guess what I don't want to do here is make assumptions that somebody who is very muscular is using steroids or abusing steroids. And there are some telltale signs. You might get you might be lots of like acne on the back or quite spotty. You might get quite muscular upper body. Sometimes they have erectile dysfunction or testicular atrophy. Although, to be honest, that's probably not something I'd start to ask at the very beginning of the consultation, but it's something I might be thinking about. But if he says he hasn't been using anything over the counter, then I have to believe him initially. And then maybe I'd come to it again if things didn't work, if things didn't make sense, if it didn't fit an illness script, if it didn't fit a picture that is familial to me, then I'd probably challenge that.
Fair enough. So shall we examine him?
Yes, please. I'd like to know his observations.
Yeah. So heart rate 112.
Ooh.
Regular. Blood pressure 146/91.
Okay.
Respiratory rate 22. Oxygen level is 96% on room air, and his temperature is 36.7.
Did he have a glucose done?
He did have a glucose done, and it was normal. It was on the VBG.
Okay.
It was normal.
And the reason I'm asking that is if he's on steroids, that can sometimes cause that catabolism in the high glucose. Okay. I mean, those observations are worrying. It's tachycardic. It's slightly hypertensive. His respirate's high. So although his saturations are okay, with those observations, actually, yeah, this could be a PE.
Fair enough.
But the blood pressure is quite high. So what could be causing the high blood pressure? Could it be the steroids that he's taking that are activating the cortisol within his adrenal gland? You're going to get some more aldosterone, which is absorbed, basically taking more water on and causing hypertension. Or is it something weird and wonderful? But I want to know what else have we got on examination?
Okay. So he's very well built, very lean. He was a bit anxious, but not pathologically so. Understandably anxious, considering he wasn't feeling very well. He had no extra work of breathing. And on examination of the chest, his heart sounds were normal. His JVP was not elevated, and there was no peripheral edema either at the ankles or at the sacrum. His chest sounded clear. There were no masses in the abdomen and no lymphadenopathy detected. He did not have pale conjunctiva. A gross neurological examination was normal, and there were no thyroid masses I could palpate at all when I was feeling for the thyroid.
Did he have a rash anywhere?
No.
Any acne?
No. And I should say, his social history was that he was a personal trainer and model part-time. So
like a fitness model.
Yeah, so he was very well kept.
Oh, I've just thought.
Not the kind of person who would tolerate a bit of acne, I think.
Okay. Is he buying Mounjaro, Ozempic?
That is a really good thought, because I think a lot of people are. And I think there's a stigma to it that people will say they haven't when they have.
I agree.
And I've had a couple of patients recently who've actually presented with euglycemic ketoacidosis. And I've said to them, absolutely no judgment, to make sure I treat you properly and give you the right medications. Are you taking Mounjaro or Ozempic? Because we know that can trigger this biochemical abnormality that we're seeing in you. Absolutely not. No way. Oh, okay. I believe you. But it is a more and more valid question, I think, because I think the people who are taking the GLP-1 drugs, because you don't really need much to get hold of them in the UK now. You can buy them online at a clinic. And we're starting to recognize some what used to be case report data, but now is amassing into critical mass, and some really good data about the side effect profile of these drugs, which are largely extremely safe, but we are recognizing some patterns.
Okay. None the wiser. Okay. So I've written 2 words. I've got 3 things down. I've got thyroid. This is what I've wrote. Thyroid, pheochromocytoma, drugs, Mounjaro, Ozempic. So obviously that's where my thought processes are going. But I would like some blood tests, please.
Yeah. So we did some routine bloods, FBC. I've got a hemoglobin of 180. I've got a
180.
180.
Oh, that's high.
I've got a white cell count of 7.2 and platelets of 312.
Okay.
On his user needs, I have a sodium of 137, potassium of 4.6, and a creatinine of 111.
So a little bit high, but
A little bit high, but very commensurate with his body, his muscular
Yeah.
mass, you know?
yeah.
And his LFTs, his ALT was 122, which is slightly up. His ALK phos was 88, and his bilirubin was 14.
Did you do a CK?
I didn't actually.
I'm just thinking of muscle breakdown and okay.
CRP was 6.
Mm.
Yep, thyroid function came back, and he was euthyroid, so TSH was in range.
Okay. You said his glucose was also within normal limit.
Yep. Yeah. I also did an ECG, which just showed a bit of sinus tachycardia.
Did you do a D-dimer?
No. Maybe I should have done for my PE, but my Wells score was very low. My suspicion of PE was through the floor.
I mean,
basically.
his PERT would be 0, wouldn't it?
His
No,
PERT.
it wouldn't. PERT.
I think it would be 0.
But with a tachycardia.
Well, shall I do it now? Let me just have a quick look.
PERT. What am I thinking? Calling it PERT. Pulmonary. I mean, it's really like criteria. PERC, not PERT.
Yeah.
Okay.
Pulmonary emblem calculator. Right. Age over 50? No. Heart rate over 110? Yes.
Yes.
SATs on Rimmel less than 95? No. Leg swelling? No. Hemoptysis? No. Recent surgery? No. Previous PE? No. Hormone use? He says no. So that gives him a score of 1.
So we can't rule it out.
We can't rule it out. If any criteria positive, the PERC rule cannot be used to rule out a PE in this patient. Well, I probably should have done a D-dimer then, shouldn't I?
Did you do a chest X-ray?
Yeah, I did. Clear lung fields, no consolidation, no pulmonary edema. Maybe very mild, I don't know, maybe mild cardiomegaly, cardiothoracic ratio might have been a bit larger than 0.5.
Oh, gosh. So you've got 29-year-old who's breathless, who's tachycardic, and is actually not anemic at all. In fact, is polycythemic.
Yes.
Is he a smoker?
No.
Alcohol?
He says almost none.
Okay. Is he got a partner?
He did have one female partner, yeah.
Okay. Just thinking about, I always think about sexually transmitted diseases, HIV. I always don't. Any foreign travel, but you said he hadn't had any travel.
No. It's funny, isn't it? I was a bit stumped.
I was
almost tempted myself to cut him free and basically say, look, I've really investigated you here and I come up with nothing except a mild tachycardia. Go on, challenge me.
So have we investigated him? Are we happy that we know the cause of the tachycardia? No. Are we happy that we know the cause of the polycythemia? No. Are we happy that we know the cause of the hypertension? No. So there are too many things here that I can't fit together. They're quite disparate, but I can't answer why they are like that. So this is where I get this is a bit odd. I'd want to just double check about drugs again, about the steroid usage maybe, any amphetamine usage, although again, not as common as it used to be.
I think it's I was in a similar place. So part of me was saying, I've investigated you enough. I've not found anything concrete, pathological, anything that's pathognomonic of a condition. Look, go back to your GP if this doesn't settle, but maybe it will settle. And whatever it was, give it a bit of time. But on the other hand, I had a few little pink flags, no red flags.
Yeah.
You're allowed to be a bit tachycardic and a bit hypertensive when you're in a hospital. It's a stressful place to be, right? But maybe it was something I shouldn't ignore. The only thing I thought I'd do, belt and braces approach I had not done to work this gentleman up would be an echo, just to make sure there was no cardiac cause for this.
And you can do echoes, can't you?
Do you mean me personally?
Yeah, you can do. You're trained, aren't you?
I can, but I rarely do them
okay.
yes, if you want to do a proper 45-minute echo and look, the LV strain rate and diastolic function and all that sort of thing, I'll let the professionals do it. So I said, I'm happy for you to go home, but let's get an echo. Our next echo slot in ESTEC, we have a couple of slots a day. The next one is on Tuesday, and today's Friday. So go home. Over the weekend, if you become unwell, come back to us anytime, but I think you'll do until Tuesday. Come in, we'll do this echo on Tuesday morning. We'll get the results there and then, and we'll just make sure we've not missed anything else. And that was my plan. And I felt that was quite reasonable. And I knew that I admit him for an echo, an inpatient echo. I really didn't have the justification to do that. Do you agree?
Yeah, I mean, I've got a couple of questions. Number one, what was his MCV and hematocrit?
Right. His MCV was normal. It was a high 90s. And his hematocrit was slightly elevated. But I think I haven't got the exact number.
Okay.
What are you thinking?
I was just thinking sticky blood. I don't know what I was thinking, to be honest. And the other question was something to do with blood pressure. Would you give him medication to reduce his blood pressure because he was hypertensive?
Not in a million years.
No, me either. But I just wanted to check, because I know that some people may give treatment for that blood pressure.
I'd hand in my badge first and quit. I feel quite strongly about this. We should not be messing around with people's high blood pressure in an outpatient setting or in an acute health event when they are hyperadrenaline and hypercortisol.
Absolutely.
They go home, that amlodipine kicks in 18 hours time or whatever its half-life is, and then he's 70 over 30 tomorrow morning and he can't get out of bed. So do that at your peril. But I've certainly never been one for the stat amlodipines, and I really encourage listeners not to go down that route either.
Yeah, and I completely agree. Unless it's hypertensive urgency or hypertensive emergency, which is obviously two very different things. I do see a lot of nifedipine usage because it has about a 6-hour onset of action versus amlodipine. But again, there's very little evidence around that. And I've seen patients come in and you check their blood pressure and it's high, and you check it again and it's high, and you keep checking it. And the blood pressure's of course going to go up because they're in a stressful environment. So I'm fully on board with that. Okay, so I agree with you, actually. I think that you did the right thing.
Good. So Tuesday comes, he comes back in, has his echo. Let me just pull up his results here. Findings. Severely dilated left ventricle.
I knew you were going to say that.
Global hypokinesis with no regional wall motion abnormality. Left ventricular ejection fraction, approximately 20 to 25%.
Oh my gosh.
Mild LV hypertrophy, no significant valvular disease, and RV function mildly impaired. How does a 29-year-old healthy man end up with a heart this weak?
Hereditary?
Okay.
That could be one option, maybe. Drug use. I'll keep going back to drugs, and I don't know why. Is that a cognitive bias of mine? Maybe, potentially. Ben, I don't know.
So we would do obviously a genetic screen for inherited cardiomyopathies, as you say. We would do a viral screen looking for viral cardiomyopathies.
Yeah,
and of course, he needs a cardiac MRI, doesn't he? And these patients often end up getting cardiac biopsies as well after their cardiac MRI under cardiology teams to see if they can work on why he should have this dilated, what looks like a dilated cardiomyopathy. You keep going back to drugs.
I'm sorry. And that's a big bias of mine, isn't it? And I don't know why.
Okay. Maybe I'm going to reinforce your bias. I went back to him and I said, I know we've talked about this and you don't take any recreational drugs. I really have to know, do you take any supplements? Do you take any performance enhancers? Do you take anything from the gym? And it all came out.
I knew it.
You called
it.
Yeah.
So
Yeah. He uses performance enhancing drugs, PEDs. This is what is often used now instead of the old word anabolic steroids, although of course they are the same
they're
thing.
mixed with everything, aren't they? They're mixed with other drugs as well, aren't
Well,
they?
let me give you a crash course in
Yes, please.
performance enhancing drug use. This gentleman he admitted to using cycles, which means they go through 6 to 8 weeks of taking very high intensity anabolic steroids for muscular gain. Then they drop down to a maintenance dose or a very low dose, or occasionally no dose at all. And they do this to make sure they don't switch off their own endogenous testosterone production, because they don't want to suppress the axis too much. This is gym bro science. It's actually very, very in depth. He also does something called stacking. Stacking means where they take multiple different PEDs, anabolic steroids, together to maximize muscular gain. And he was also doing, and that cycling where you take a big dose, then you go drop it down, it's often called blast and cruise. So you blast the steroids, then you cruise on a lower dose. You don't lose all the gains that you've made. He's been using them intermittently for years. He was also taking letrozole and anastrozole to lower his estrogen, he said. And this is because very commonly people who take anabolic steroids are aware that in the body, they undergo aromatization into estrogen, which could cause problems such as erectile dysfunction and gynecomastia. So therefore, a lot of people will also take aromatase inhibitors. Maybe you're familiar with letrozole and anastrozole. We give them to women who have hormone receptor breast cancers in order to inhibit that aromatization process of testosterone into estrogen. So he was heavily, heavily into this. We do know that prolonged anabolic steroid use can cause cardiomyopathy due to unknown mechanisms. Probably direct myocardial toxicity is associated with fibrosis and remodeling of heart muscle. Also hypertension. That polycythemia, we noticed the HB is quite common with testosterone use as well, actually, where you get elevated hematocrit as well. Unfortunately, the side effects are multiple with these drugs. Cosmetics, you might say, balding, acne, but also testicular atrophy, endogenous suppression of urine testosterone, as I've mentioned, mood changes, depression, even psychosis. This isn't just about cosmetic drug use. They are potent endocrine and cardiovascular agents, and they're out there. And they're actually really, really common. And they're getting more and more common amongst healthy young men who attend the gym. And you could go into a huge rabbit hole about why that should be. It's associated with the rise of social media, getting the Instagram perfect body, reality television. There are I find quite childish names such as which sort of don't really give due justice to what's going on, but something called bigorexia, where they look in the mirror and they see a skinny person, but in fact they're incredibly musculous. They're always chasing the higher high. And when I spoke to him and said, your life is going to be very different now, you can never, ever take these drugs ever, ever again. He was destroyed. He was absolutely destroyed. I don't know who I am without my body and my gym like this. This is my job. I'm an influencer. I have thousands of followers online. I can't give this up. It's my identity. I don't think I ever could, even if you've told me that I've cut my life expectancy by 20, 25 years. I don't think I could stop doing this, because I'm nothing if I get skinny, or if I lose my muscles, if I lose my self-identity. It was a very, very strange, intense conversation. Have you ever encountered this before?
I haven't. I have seen quite a few men who are taking anabolic steroids, but not to this level, or maybe I didn't delve into it enough. It's really scary, isn't it? I mean, but I get it. I get it, because there's body shaming out there, there's a lot of social media has a lot to answer for. And I really worry about the younger generations coming up and seeing this, and how, body dysmorphia and how you're perceived.
Yeah.
It's incredibly sad.
It is. And I think it isn't athletes I always thought it was athletes, who got banned because they were chasing the ultimate records. You're trying to break their own personal best. They're not. And the users that we're going to see are not elite athletes. They're just ordinary young men who are chasing an impossible body standard, absolutely impossible body standard. So what happened to my guy? He needed to start some treatment. He had to start the 4 pillars of heart failure management.
Gosh.
ACE inhibitor, or Entresto, a beta blocker, an MRA, spironolactone, an SGLT inhibitor. He had to stop taking all of his anabolic steroids. I did follow him up, his notes up, and when he attended a cardiology follow-up a few months later, his ejection fraction had improved to 40 to 45%.
Wow,
so he had some recovery.
Yeah.
But this is lifelong medication for him now. And at the age of 29, I mean, he could be somebody who in his middle age is looking at a heart transplant. Massive, massive surgery. So what unlocked it? You said steroids practically from the get-go, and the patient denied it. And I think what we need to do is, of course, we approach it with a non-judgmental tone and attitude, and from the point of view saying, I only want to make sure I give you the best treatment that you need. That's why I'm asking. I'm not going to tell anybody. I'm not going to shame you. I'm not going to judge you. But I think what unlocked it in this case was no drugs, no recreational drugs, because he didn't see this as a recreational drug.
Yes.
So you've got to say, if you have really big muscular individuals with a very low fat mass, very, very lean, the questions are you taking any hormones? Are you taking any supplements? Are you taking any gym drugs? Are you taking any testosterone? Are you taking any anabolic steroids? So you've got to name them, because they might not classify them in their own minds as a drug.
Where was he buying it from? Was it on the internet?
Yeah, you could Google. I won't teach any listeners how to do it. You could Google steroids in the UK, and you could go to a website. You can buy. Lord knows what you're buying. These labs are not high grade labs. These are labs in people's kitchens, and what the content is of the pills that you're popping or injecting is absolutely anyone's guess. It's a really, really, really dangerous road to go down, because these are sort of homemade labs. But there you go. Would you like to know some of their names? I was doing some research.
Yes, please. Yeah.
Okay. So the big one is testosterone, obviously. They call it. Tren.
Tren?
Tren. T-R-E-N. Tren. Very big in the gym locker room, short for trenbolone. It's actually a very potent veterinary steroid that causes severe hypertension, but massive gains. Dianabol, they're called D-bol or D, is another big one as well. That one's quite hepatotoxic, so they know they got to keep an eye on their LFTs. And a lot of them take milk thistle to go with it, because they think it sort of purify the liver. DECA, D-E-C-A. This one's more associated with sexual dysfunction. Winnies, that's short for Winstrol. Are you taking Winnies? Then that one is linked to hyperlipidemia and lipid changes. Another big one is HGH, human growth hormone, which is injected and is linked to insulin resistance and cardiomyopathy and acromegalic features. Yikes. So they're really common ones. And what you might see as well is the letrozole and the anastrozole, which I mentioned, which they use to avoid the estrogen effects. And you might see them using something called Clen, which is clenbuterol. Clenbuterol is actually a beta agonist, a bit like salbutamol, but it acts on the adipocyte receptors, and it helps you burn fat. So they often take it as a supplement. But this, of course, can cause tachycardias and arrhythmias and things, just like a nebulized salbutamol can. So now you're going to say, listen, you told me you're not taking any drugs. I see you're a very, very well-built person. You go to the gym. Are you taking T, Tren, Winnies, D-bol? Any Clen? Now you're down with all the lingo. We can ask the right questions.
Yeah, it's
a bit depressing, isn't it?
It is, but it also makes me wonder how many people I may have missed who have been taking these medications that I haven't asked specific questions. And you know me, I'm always about open questions, letting the patient talk. But I think it's also really important when we have cases like this to be very specific. Do you take... I had a patient years ago who had lead poisoning and had been had been buying medication off the internet. And do you take any medication from the GP? No. Do you take any over the counter? No. Didn't ask if they bought anything on the internet.
Yeah.
So sometimes you have to be really specific, don't you, about
Yeah.
the questions that you're asking.
Yeah. And that should be our next question. When I learned social histories, I asked about smoking and drinking.
Yeah.
And then I had to learn to say, and any recreational drugs, because
Yeah.
I wasn't taught that bit really at medical school. And now I have to learn to say, and are you buying any other drugs or supplements or hormones on the internet, including
Anything.
Manjaro or anabolic
Yeah.
steroids? Because I think that's something that we are going to be seeing more and more of.
Yeah, I agree. Absolutely. Wow, that was a really, really interesting case. Thank you so much, Ben. It didn't go where I thought it was going to go, which is why medicine is continually brilliant and interesting, because I've been a doctor for 20 years and I learned something new today. So you never stop learning. Yeah.
Good. You never
Thank
stop
very
it.
much.
And I hope our listeners have learned something they find useful going forward. And I think that's taken us to the end of the episode. So thank you so much, Amie, for playing along.
you.
Thank you so much to everyone for listening. Of course, please do tell all your friends about this podcast, and do take a second to rate or leave a review on whatever app or platform you're listening to us on, because it helps us grow our podcast and reach new listeners. Thank you so much, everybody. Have a wonderful rest of the day, and goodbye.
Goodbye.